She ate chicken in Costa Rica. Not ceviche, not sushi, not raw anything. Grilled chicken thighs from a roadside soda in Monteverde. She watched the cook press it flat on the grill with a brick. She ate every piece with her fingers. She posted a photo to her story, caption, "Living my best life." 3 months later, something was crawling under her skin. She could feel it move. She could see the bruise trail it left behind, and no doctor on 2 continents could tell her what it was. She did not eat raw fish. She ate chicken. Remember that. This is Diagnosis Glitch. Names have been changed for privacy. This story is based on true events and documented medical cases. Her name is Lily Brennan, 22 years old, final year physiotherapy student at the University of Leeds. She deferred her last semester to take a gap year. 8 months, Central America, then Mexico. She had a spreadsheet, every hospital, every bus route, every vaccination the travel clinic told her to get. Hepatitis A, typhoid, yellow fever. She got them all. She packed doxycycline for malaria. She carried a filtered water bottle she refilled twice a day. She knows the human body well enough to treat other people's injuries. She doesn't know what's about to happen inside her own. Jess Okonkwo is her travel partner, 23, nursing student at King's College London. She and Lily met in a backpackers Facebook group 6 months before the trip. Jess is quieter, more skeptical, the one who reads the bad reviews before booking a hostel. She carries a first aid kit with suture strips and oral rehydration salts. She once diagnosed a Dutch backpacker's dehydration in a Guatemala City dorm room before the guy knew he was sick. She reads symptoms the way Lily reads bus timetables. Remember that too. Here's the detail that reframes everything that follows. The parasite is called Gnathostoma spinigerum, a nematode worm, 3 to 4 millimeters long. It has a hardened head called a cephalic bulb covered in 4 transverse rows of cuticular hooklets. These hooklets are not for feeding. They're for anchoring. The worm grips tissue and pulls itself forward through your body inch by inch, organ by organ. It's a biological drill bit with no off switch. But here's the part that should keep you awake tonight. The worm is programmed to mature inside cats and dogs, specifically inside their stomach walls. In a human, the worm reaches the stomach and finds nothing it recognizes. No chemical signal to molt, no hormonal cue to settle. It's trapped in a larval stage. It can't grow up, it can't reproduce, it can't die on any useful timeline. So it does the only thing its biology allows. It wanders through muscle, through fat, through connective tissue, through your organs for years. Dr. David A.J. Moore at Imperial College London documented cases where the worm migrated continuously for 10 to 12 years. Not months, years. A living thing, smaller than a grain of rice, dragging itself through a human body for over a decade because it's biologically lost. And it does not come from raw fish. Foraging pigs and free-range chickens in rural Central America drink from contaminated ponds and streams. The larvae burrow into their muscle tissue and wait. When you eat undercooked poultry or pork, the larvae wake up. They bore through your stomach wall and start walking. Lily did not eat sushi. She ate grilled chicken at a roadside restaurant in Costa Rica. The travel clinic never mentioned this. Month 3, Monteverde is behind them. They are 2 weeks into Mexico, staying in a hostel in Oaxaca, when Lily gets sick. Fever, headache, nausea, 72 hours of what feels like a bad stomach bug. She takes paracetamol, drinks electrolytes, Jess checks her temperature every few hours. By day 4, the fever breaks. She feels weak but fine. She blames it on a dodgy taco. She's wrong. The fever was not a stomach bug, it was an alarm. The larva had already bored through her stomach wall and was crawling into deeper tissue. Her immune system threw everything it had at the intruder. The intruder ignored it. 1 week after, the fever breaks. The pain starts. A deep, stabbing ache in her right calf. Not a cramp, not a pulled muscle. She's studied musculoskeletal anatomy for 3 years. She knows what a muscle strain feels like. This is different. It sits deep inside the gastrocnemius, like someone has pushed a hot needle into the center of the muscle and left it there. She stretches, she ices it, she takes ibuprofen, Jess wraps it with an elastic bandage. Lily assumes she pulled something on a hike. She's treated this exact injury in clinic rotations dozens of times. Rest, ice, compression, elevation. She follows her own protocol perfectly. The protocols for an injury that does not exist. 2 days later, the pain's gone from her calf. It's in her left thigh. Not sore, stabbing. A localized pulsing heat deep in the muscle belly that wakes her at 3 in the morning. Then her right forearm, then her shoulder, then her calf again. Every few days, the pain moves. It appears in a new muscle group, burns for 48 to 72 hours, then vanishes and reappears somewhere else. This continues for 6 months. While Lily traveled through Mexico and flew home to London, the worm was crawling. Through the connective tissue between muscle fibers, through the subcutaneous fat layer beneath their skin. Each time it moved, its hooklets tore a microscopic trail through living tissue. The body responded by flooding eosinophils to the site. Eosinophils are the immune cells designed to kill parasites. They dump toxic granules, major basic protein and eosinophil catatonic protein directly onto the invader. But the worm's cuticle's too thick. The granules bounce off the worm and destroy the surrounding human tissue instead. That's the burning. That's the deep ache. Her own immune system unable to grip the target, scorching the flesh around it. And the worm leaves a trail you can see. Subcutaneous hemorrhagic tracks. A wide purplish-red band of internal bruising beneath the skin like a blunt instrument was dragged under the epidermis. The worm secretes anticoagulants as it moves, preventing the blood around it from clotting so every inch of its path bleeds internally. The bruise shifts. It appears on her forearm one morning and is on her ribcage 2 days later. Lily showed Jess the first visible track on a bus from San Cristobal to Mexico City. A dark red streak 3 inches long running diagonally across the inside of her left forearm. Jess stared at it for a long time. That's not a bruise. I know. It moved. 9 months after that chicken dinner in Monteverde, Lily is back in London. She's seen 4 doctors, a GP in Mexico City who told her the shifting pain was stress-related, a walk-in clinic in Cancun that diagnosed a spider bite on her forearm, her GP in Leeds who ran blood work that came back unremarkable except for mildly elevated eosinophils, a detail that was noted in the file and never followed up on, an urgent care physician who was diagnosed cellulitis and prescribed a course of antibiotics that changed nothing. 4 doctors, 3 countries, 0 correct diagnoses. Median time to diagnose for Gnathostoma, 12 months. Some documented cases, 5 years. 4 doctors in 9 months is fast by global standards. That is the state of the system. The cellulitis diagnosis is the one that stings the most. Cellulitis is a bacterial skin infection. It does not move. It does not leave hemorrhagic tracks. It does not shift from limb to limb over weeks, but the physician saw red, swollen skin, reached for the most common explanation, and stopped looking. Lily took the full course of antibiotics. Nothing changed. None of them asked if she had eaten undercooked poultry in Central America. The intake forms asked about raw fish, about shellfish, about unpasteurized dairy. No form on 2 continents contains the question that would have changed everything. Did you eat chicken or pork in a rural area where livestock drink from open water? Jess finally made the connection. She was 3 months into her clinical placement at Guy's Hospital in London, rotating through the infectious diseases ward. A consultant mentioned a case of migratory paniculitis in a returned traveler. Jess stopped writing her clinical notes. That night, she sat at the desk in her flat with 2 browser tabs open. Lily's symptom timeline on the left, PubMed search results on the right, migratory Malaysia, subcutaneous hemorrhagic tracks, Central American travel history, eosinophilia, she typed, Gnathostoma spinigerum. Every line matched. The shifting pain, the bruise trails, the chicken vector, the eosinophils nobody followed up on. She called Lily at 11 at night. I need you to get a referral to the Hospital for Tropical Diseases tomorrow. The Hospital for Tropical Diseases in London is one of the only facilities in the United Kingdom equipped to diagnose gnathostomiasis. When Lily arrived, she brought 9 months of medical records, Jess's printed PubMed papers, and a photograph of the hemorrhagic tract on her forearm. The ID specialist examined her. took one look at the subcutaneous tracts, asked her 3 questions: where did you travel, what did you eat, when did the migratory pain start? He ordered an MRI of her right leg. It showed a small signal abnormality deep in the gastrocnemius muscle, a radiological footprint of the migrating larva, a shadow where no shadow could be. But the specialist could not confirm the diagnosis with a blood test. Not in London. Not anywhere in the Western Hemisphere. The CDC doesn't offer commercial serologic testing for Gnathostoma. There is no rapid test. There is no point-of-care kit. Blood samples must be physically shipped to the Swiss Tropical and Public Health Institute in Basel, Switzerland, or to Mahidol University in Bangkok, Thailand. 2 labs on Earth, neither in the country treating her. Her blood was drawn in London, packaged, shipped to Basel. The results would take weeks. Lily sat in the consultation room and asked the specialist what happens if they wait. He told her the truth. Untreated, the worm can migrate for 10 to 12 years, and in documented cases, when it reaches the eye, it causes permanent blindness. When it reaches the spinal cord, it causes permanent paralysis. She asked if they could start treatment while they waited for Basel. He said, "We need a confirmed diagnosis before we prescribe." The test existed. It sat in a freezer in Switzerland. Lily was in London, and nobody could treat her until the results came back. For 11 days, she waited. She sat in anatomy lectures and traced the perineal nerve on a cadaver while something alive traced its own path through her body. On day 6, a new hemorrhagic tract appeared across her ribcage. Dark red, 6 inches long. She photographed it and sent it to Jess. Jess forwarded it to the specialist. He documented it in her file and wrote, "Consistent with ongoing larval migration, awaiting serology." Awaiting serology, while the worm crawled toward her spine. Here's where the system nearly broke for good. An ER physician who suspects a parasite in the UK faces the same trap as one in the United States. You cannot legally justify prescribing an off-label anti-parasitic drug without a confirmatory lab test. The test takes weeks. The worm does not wait weeks. Standard of care becomes the thing that paralyzes you. In our last video, a man in Chicago waited 40 days for an endoscopy while a different parasite bored through his stomach wall. The pattern's identical. The system demands proof before it acts. The parasite does not wait for proof. The specialist at the Hospital for Tropical Diseases did what experience taught him to do. He documented a clinical diagnosis without lab confirmation based on the 3 things no other condition explains: swelling that moves, bruise trails that shift, and elevated eosinophils in a woman who just came back from Central America. He consulted with colleagues. He built a paper trail that would protect him and his patient. Then he prescribed empirical treatment without waiting for Basel. Ivermectin first, 200 micrograms per kilogram for 2 days. The eosinophil count dropped. The immune siege backed off. But ivermectin does not kill Gnathostoma. It stuns it, slows it, takes the edge off. The definitive weapon was Albendazole, 400 milligrams twice daily for 21 days, a 3-week course of a drug that crosses into every tissue compartment in the body and poisons the worm's ability to metabolize glucose. It starves. It stops moving. It dies inside the tissue where it finally ran out of fuel. By day 7, the pain stopped shifting. For the first time in 6 months, Lily woke up and nothing new hurt. By day 14, the hemorrhagic tracts had faded to faint yellow shadows. By day 21, she touched the inside of her forearm where the worst tract had been and felt nothing. No heat, no tenderness, just skin. By the 6-week follow-up, the eosinophils were normal. The MRI was clean. 9 months of agony resolved in 3 weeks by a drug that cost less than £5 per tablet and could have been prescribed on day 1, if anyone had asked the right question. Lily called Jess from the hospital corridor after her final follow-up. Her voice was steady for the first time in 9 months. "It's gone," the specialist confirmed. "No more movement, no more tracks." Jess was quiet for a moment, then, 9 months. I was on the ID ward for 2 weeks before I had heard the word that solved it. But the worm does not always stay in the muscle, and the system does not always catch it in time. A 24-year-old woman in Madagascar noticed swelling in her right eyelid. She went to a doctor immediately. Because Gnathostomiasis is not endemic to Madagascar, doctors did not consider it. They diagnosed infection, prescribed antimicrobials. 1 month later, the worm had crossed to her left eye. It was visible, alive, and moving in the interior chamber of the eyeball. By the time it was extracted, the delay had caused permanent blindness in her left eye. A 40-year-old woman in New Zealand developed severe electric shock pain shooting down her spine, numbness spreading through her legs. She had no Asian travel history. She had eaten local fish. Doctors diagnosed Toxocara myelitis, a different parasite entirely. Over 14 months, she deteriorated into spastic paraparesis, wheelchair-bound. When the correct diagnosis was finally made, treatment stabilized her condition, but the neurological damage was permanent. She will not walk again. Dr. Norman L. Betty at the University of Florida and his co-authors published a warning that should be required reading in every Western medical school. They named Gnathostomiasis as a neglected disease and identified a lapse in CDC laboratory services that created critical delays in diagnosis and treatment. The CDC itself, the institution that exists to prevent exactly this, does not have the test. They tell you to contact labs in Thailand and Japan. Dr. Moore at Imperial College wrote the sentence that haunts me. The rarity of the condition, combined with the usual absence of physical signs between episodes, may lead to discounting of the symptoms and erroneous reassurance of the patient by clinicians unfamiliar with gnathostomiasis. Erroneous reassurance, a clinical term for telling a patient nothing is wrong while a worm drills through their body. Here's what I need you to understand. The glitch in this story is not the worm. The worm's doing exactly what its biology demands. Lily was an accident, a dead-end host in a lifestyle cycle that has nothing to do with her. The glitch is the question nobody asks. Every intake form in the Western world asks about raw fish, about shellfish, about sushi, because the medical establishment built its parasite framework around one vector and stopped updating it. Gnathostoma does not care about that framework. It lives in chickens, pigs, frogs, in animals that drink from ponds where the larvae swim freely. The question that would have caught Lily's infection on the first visit, did you eat undercooked poultry or pork in a region where livestock drink from open water, does not exist on any standard form in any country she visited. And even when a specialist finally suspected the answer, he couldn't prove it. The CDC directs you to laboratories in Basel and Bangkok. The test does not exist in the country treating the patient. Lily told me something I can't stop thinking about. She said, "I can name every muscle, every nerve, every tendon in the human body." I described a textbook case to 4 doctors across 3 countries. The thing that diagnosed me was not a test, it was not a scan, it was my friend overhearing one word on a hospital ward that none of those doctors thought to say. The next time someone hands you a plate of chicken at a roadside restaurant in Central America or a pork skewer at a night market in Southeast Asia, remember the syphilic bulb, the hooklets, the hemorrhagic tracts, the 10 to 12 year migration through your body because the worm is biologically lost and has nowhere to go. And remember that the test to find it does not exist in the United States, and the question that would catch it is not on any form. This is Diagnosis Glitch. I'll see you in the next waiting room.